The next domain of healthcare delivery that we're going to discuss is access, otherwise also referred to as access to healthcare services. Now, there is a general consensus among healthcare policy analysts that there is an inequality in terms of having access to healthcare in the United States. And a lot of this is blamed on our country's lack of or not having universal healthcare. We do have some sort of mechanism in place, but it appears that it is not as efficient as those other industrialized countries where they have a universal healthcare system. Now, not all of them have a single payer system, like Germany, for instance, has multiple payer systems. But the fact is, they do have a universal healthcare system, and therefore, in theory and in principle, everyone has equal access to healthcare. Since we do not have that, it's quite evident that the general population, and if you look into subgroups, some subgroups have better access to healthcare and some do not. Now, let's define access to care. So access to care is simply defined as one's ability, or the ability of a citizen or a resident of the United States or an individual to obtain needed, affordable, convenient, acceptable, and effective personal health services in a timely manner. Now, that's a lot of conditions to meet, but as a matter of fact, that is how access to care is determined. You got to be able to get it when you need it. It should be affordable, meaning you can afford it in terms of paying it, or you have a third-party payer source that will pay for it. It should also be convenient, meaning if you live in a rural area, you don't have to drive an hour just to see a primary care provider. Acceptability could be subjective because you don't really know what you're missing if you don't know that there's something better out there. But this is a question wherein quality of healthcare should be uniform all over the country. And of course, effective, meaning it does what it is supposed to do, meaning to bring out wellness and treatment that is effective and, deals with that disease problem or the burden of that disease problem in any given community or a particular person. Now, access is a determinant of health status, meaning having access to care has a lot to do with the status of your health. And access, therefore, because it affects your health status, can also be cost of the environment, can be directly related to the environment that you're living in, the lifestyle that you're living in, and the hereditary factors. Now, all these things will determine how much access to care you need. So, although health insurance is not just the only factor that can determine our access to care, research have shown that because of the current status of the way we make healthcare services available to people, have shown that having health insurance is the single and the most reliable indicator of an individual being able to access healthcare in the United States. In other words, if you don't have any health insurance, you're more likely not to be able to, meaning you're less likely to be able to access healthcare when you need it. So what are the things that we know about access? Well, there's a lot of data available. This data that we have is very important because it helps the government determine problems and issues pertaining to the unevenness and the inequality in terms of different subgroups in the country in terms of having access to healthcare. So the government itself collects a lot of data from community health centers. Community health centers receive funding and from the federal government, and in return, every year, health centers actually have to report back data. We will talk more about this when we talk about primary care and community health centers. The government is also closely monitoring certain diseases. As a matter of fact, a lot of diseases are being monitored, like HIV and AIDS, and of course, mental health as well. And then from the state level, the states also collect their own data, epidemiological data. Nonprofit organizations such as, for instance, the American Heart Association, the American Cancer Society, they collect all this information and they all feed up into the main data bank and main knowledge we have about accessibility of healthcare services. Now, managed care or insurance companies themselves do collect data on access. So going back to the inequalities in terms of accessibility of healthcare in the United States, time and time again, research has shown that those who are poor, those of low socioeconomic status, and those who belong to minority group members seem to demonstrate lower overall healthcare usage, and probably because of the disparities and the inequalities in terms of accessibility to healthcare. Persons who are not white, under 65, are 5 to 20% less likely to have any type of insurance. And racial and ethnic minorities are less likely than those their white counterparts to have a specific ongoing source of care, meaning the minorities, are likely not to have a continuous source of primary care and secondary care and tertiary care, meaning they probably get it as they need it and there is no continuum of care. Whereas white counterparts tend to have primary care providers and there seems to be a more seamless and organized delivery of care for this particular groups of people. There are several reasons for this inequality in access. And the main thing we're going to talk about are barriers. So barriers are those things that prevent people from accessing healthcare when they need it. Now, there are two levels of barriers, and they exist at the individual and at the systemic level. Now, on the individual level, this would be the demographics issue, minority origins, low socioeconomic status, low income, less education, having certain types of disabilities, having chronic illnesses, and being uninsured. Now, system level refers to the infrastructure and the environment that is sort of systemic that surrounds the individual. So whatever is in your environment that prevents you from accessing care is called a system level barrier. One perfect example perhaps would be in neighborhoods in the Bronx, for instance, that have elevated subway tracks. And for mothers with infants that have strollers, to bring them to doctors for pediatric appointments, that is already a barrier in itself to be able to. And what if it is the only mode of transportation that is available? And what if you cannot afford a taxi service or an app hailing service, ride service like Uber? So if your only choice is the subway, and that makes things harder. Also having that type of work where you cannot just easily take off just to take your kids to school, to the doctor, that is also a barrier. Now, access can be predicted, therefore, by race, income, and occupation, because race, income, and occupation could be the very source of this particular individual and system level barriers, which prevent people from accessing healthcare, or at least makes it difficult for them to access healthcare when they need it. So how then can we resolve the issue of inequalities and that causes disparities in access to care? So in the United States, there are two opposing philosophies that regulate access. And again, this is one of those topics I told you about that are not necessarily in this chapter. But if you refer to pages 33 to 36 of your textbook, you can read up on this topic. Now, this is very important because these are two philosophies that we actually adhere to, and we try to make them work together as far as the U.S. healthcare system is concerned. So the production, the availability, distribution, and how healthcare could be consumed should be perceived as equitable, right? But we already said that there's really inequalities in access. Now, why is that so? Even in countries with universal healthcare systems, no one has achieved a perfect model on how to make sure that the distribution of this limited healthcare resources are done in an equitable method, in a perfect equitable method. And because of these, any method of resource distribution, because you're distributing it, you're not making it freely available to everyone, will lead to some inequalities. So what this is basically saying is that even in countries with universal healthcare systems, there are still some inequalities that happen because the government is in charge of distributing these resources. So how do we go about in tackling these issues? Well, a theory of justice is needed to resolve the allocation of healthcare. Like, how could we actually at least reach a certain acceptable level of equitability? And the way we do it, like I said, is we both have the theory of market and social justice. Now, some social scientists would argue that the predominant philosophy we have is market, and that is probably closer to the truth. We do have some form of social justice in terms of giving access to healthcare, and we'll talk about that in a little bit. But in the United States, these two theories, which are known to be contrasting and actually are sort of like, for lack of a better term, like oil and water. You're trying to make them go together, but they really won't. And this is what then governs the production and distribution of healthcare services in the United States. Let's start off with the first theory, or the first philosophy, which is market justice, also known as the economic good. Now, market justice, which, by the way, rules or regulates the market economy, that's the same principle that we follow in the market economy, says that the fair distribution of any types of services and goods, and in this case, healthcare services, it should be distributed following the forces of the market. And this is because we have a free economy. What does this mean? It means that this healthcare services will be distributed and be made available to people only if they have the ability to pay for it, and if they have the willingness, or they're willing to pay for it. Now, that's a problem because ability, as we said, is closely tied to health insurance in this country. And not everyone has access to health insurance in this country. Now, market justice presupposes that healthcare is an economic good. It's compared to a computer, a car, a cologne, a jacket, any other economic good that you could think of. That's basically what we're saying, that what healthcare is, and because it is an economic good, it should be governed by free market forces. So if we're trying to sell cars, for instance, we have to make an argument that people actually need it, and therefore increase the demand. Market justice also believes that each of us are responsible for our own achievements, and our own achievements in this society means that we have done well, we probably have a good career, good job that provides health insurance. So having health insurance is a direct result of working hard and doing well in school and making sure you make the right choices. Now, speaking of making the right choices, just like selling any economic goods, we also assume that people would make rational choices in buying healthcare products and services. It's like when you buy a car, you do your own research. When you buy a computer, you do your own research. How much random access memory? How many gigs do I need? It's because it's a product that you're going to pay for, because it's governed by the market forces when you're trying to buy it, right? Now, in healthcare, it appears that we will be assuming people to do the same thing. Like, if I have a chest pain, I should research it and say, oh, I actually need a pacemaker. Oh no, I actually need an angioplasty. No, as a matter of fact, I probably need a heart bypass. Now, in healthcare, that doesn't work because not everyone is a doctor. Not even doctors are encouraged to self-diagnose themselves. In a market economy, when you're buying goods, well, that is fine because you can research about computers, you can research about cars, you can research about any other product that you're going to buy. Now, granted that market justice also believes that because people are not trained to be physicians, not all people are trained to be physicians, that they will consult with their own physicians who know what is best for them. But we know that having access to a physician also means that you have access to healthcare insurance. Market justice believes that just like any other economic market, it should work without or with very little interference from the government. And that the production of the healthcare services and healthcare goods will be determined by how much of the consumer is willing and able to buy at the prevailing price. And what happens is that we go back to the barriers again. Those who are not able to pay because they don't have a source of a third-party payer source, meaning they don't have health insurance, face a barrier and therefore results to inequalities in terms of accessing healthcare. This results in rationing of healthcare services by ability to pay. Those who cannot afford it, those who are not able to pay, will then not be able to access healthcare services. So market justice focuses on the individual rather than a collective responsibility for health, meaning you are responsible for your own health. That's basically what market justice does. So we tend not to be jealous of people having nice cars because we probably think, well, they worked hard for it, they can afford it. And it's their individual achievement, and that's fine. So we're trying to get that sort of concept work with being able to access healthcare as well. Let's look at the other side of the coin. What is the other theory? What is the other philosophy that we have in place? So this is the so-called social justice. And social justice presupposes that we as a community have an obligation to the collective good. We are responsible for what is good. So social justice is totally at odds with capitalism and market justice because it believes that healthcare should be equitably distributed and that healthcare is the responsibility of the community, of the society as a whole, and that it's the government, which is the central agency that should make these decisions. So instead of being an economic good, healthcare is a social good, and that it should be collectively financed, that is through taxes, and therefore those who earn more and those who earn less will have fair share of their income contributed to the funding for healthcare services, and that it should be available to every citizen. And that healthcare should be based on need rather than cost, meaning if you need it, you should be able to use it, and that we have a shared responsibility for health because we cannot blame the individual for everything that happens to him. There are several factors, for instance, that presupposes a person to be sick with certain conditions, and that those factors may be beyond a person's control. Like if you have sickle cell disease, maybe that's hereditary, for instance. So social justice, therefore, does some types of rationing. And planned rationing, supply side rationing, or non-price rationing is where the government limits the supply of healthcare. This is where some type of inequitability happens because the government basically decides where healthcare services will be made available to people. So countries with universal healthcare systems ration these services by controlling the distribution. How do we do that? By national budgeting, meaning certain areas will get more, certain areas will get less. And then government decides the prices and how much to pay providers, including drugs. And there will be some restrictions on the services that are given. And some of them will be a combination of these methods. The Affordable Care Act of 2010 and social justice, they are closely interrelated because it's one of our attempts to have more social justice in terms of accessibility to healthcare in the United States. Now, we all thought that all the provisions have taken into effect, and we all thought it was going to continue smoothly. But of course, that is not happening because one of the main components of this law, which was affirmed in 2012 by the Supreme Court, was later repealed by the Tax Cuts Jobs Act of 2017, which was pushed and sponsored by the current administration, the Trump administration. So here's a table wherein market justice and social justice are put side by side. And this column gives us the scenarios where they both work together and they complement each other. This column shows us where they do not work together. And just look at how and what the reality is. So they would complement because market justice is the one that drives the health insurance coverage for those Americans that have access to care through their jobs. And social justice works because it's the one that provides health care to those people who are entitled to them. A means-tested entitlement such as Medicaid, Medicare, etc. The problem is there are people that fall in the middle of these fine line here. And this fine line here is when these two principles do not work together. So when does it clash and collide and not work together? That is when market justice and when there are Americans who cannot afford to buy health coverage or they are unemployed. They might actually make some money, but they're self-entrepreneurs and they can't afford to buy their own health insurance. And then social justice also fails because there are Americans who might be actually employed, but in terms of their income, they're too rich to qualify for Medicaid. And these people that fall through the cracks in between these cracks where these two philosophies don't work together is the target population of the Affordable Care Act. So the target population of the Affordable Care Act are for those people who cannot get their insurance from their employer because they're unemployed or they're self-employed. They're too rich. They can't get Medicaid. What they can do is go to the marketplaces and buy their own health insurance. And based on their income, the government is actually going to help them pay for their premiums. And that is how these two philosophies work hand in hand as far as our healthcare system is concerned. Now, please familiarize yourself with this table because this clearly illustrates how both market justice and social justice work side by side in our current U.S. healthcare system.